we go. Great. So if I'll just mute all of you. Good morning, everybody. Thank you very much for joining us for the pelvic workshop this morning. I am going to start with quite a little bit of kind of theory, and I'm going to explore showing you a few slides and things on the computer, and I will also be doing some experiential learning. So we'll be doing some stuff in sitting and possibly laying as well, for those of you that are comfortable to kind of get on the floor and lay. So we'll do that sort of more in the second hour. But please make sure you fidget. The beauty of this is you're in your own homes. You can fidget, get yourselves comfy. Yeah, and I hope you enjoy. I will invite as well, I don't know how happy people will feel, but to unmute yourself, ask questions along the way, because it will also help me sort of slow down a bit probably, and at least make sure that I'm addressing some of the things that have brought you to this course, and hopefully yeah, I mean, you get the most out of it. So welcome everyone, nice to see faces, and I'll put the screen share on then now. So we'll make a start with a few slides. Oh, if I can, here we go. Okay, so hopefully you can see me as a little person in the corner now. Can I just confirm, those of you, I can see Jenny, can you see me as a little person in the corner and see the screen share? Fantastic, and everyone can hear me okay. Super, okay, so your pelvic floor, is it hyperactive or overactive or underactive, hypo or underactive, or is it a mixture? Is it out of balance? So what isn't behaving? It could be that there's a combination of the two. We can have, yeah, it being kind of over and underactive, and it's kind of, yeah, just sort of out of kilter. So actually having two separate workshops, that they do kind of merge a little together. I'm just going to see some, so just check the chat. Okay, atrophy, yeah. Okay, super. I'm just double checking the chat there. Super. Okay, so what isn't behaving, or what is dysfunctional? Possibly it's the pelvic floor itself, the muscles and the fascia, or is a change in pelvic floor activity a symptom arising from somewhere else? For example, something like endometriosis, which is a condition where tissue similar to the lining of the womb grows in other places, such as around other organs, and it causes pain, and this would cause secondary protective holding in the muscles, which will also have the effect of us maybe breathing shallower, holding protective postures, and so on. So in men, I know some men may join the course or watch the recording. So for men, something like, I don't know, an enlarged prostate, for example, might also bring about pain and the similar sort of protective holding patterns in the body. So is it the pelvic floor that's the primary dysfunction, or is it a source of secondary kind of discomfort and a secondary kind of symptom? So holding tension can also arise from a dysregulated nervous system. So if we're feeling anxious, for example, postures that hinder, I've got a few little sneaky notes on the side, postures that hinder normal diaphragm excursion causes shallow breathing, and this becomes kind of habitual. It affects our movement and our repertoire of movement, which will have an imbalancing effect to our pelvic floor. So we might not know what our habits are until we feel something different. I'm just going to move the slides down. I might get how to do that. Here we go. Okay, so this is just a little picture of, yeah, a little doggy. They obviously have pelvises, pelvic floor is the same, but we can see in this dog, it's kind of holding a certain sort of tension pattern. It doesn't look terribly confident, looks a little nervous of the water. And we also tend to hold more tension at our tailbone, a little bit tucked under, like a dog who is fearful has its tail tucked. And it's an area of vulnerability, maybe for us humans, a possible area of previous trauma, maybe childbirth, injury. And it's a pattern of muscle holding which goes with closing and protecting the body. So also with this, you might observe sort of shoulders up, knees pressed together. So for me personally, if I get pain in my perineum or kind of around the sphincter area, I recognize it, that it's likely to be triggered by kind of stress. We even use phrases in our vocabulary like, oh, you're a pain in the bum, or you're a pain in the neck. And these turns of phrase have arisen because these areas are really common areas where tension is stored in the body, so around the tail and in the neck. So how can we experiment or experience change in our pelvic floor to help a problem? Do we strengthen it or release it to relieve symptoms? Or do we need to be able to do both? So we don't know, maybe unless we have an examination of our pelvic floor, which is what women's health physios like myself have been trained to do. For this talk, I'm going to focus more on the release of the pelvic floor. And in the next course, next Saturday at the same time, I'm going to be starting with talking more about pelvic floor release, but then also talking in more detail about engaging and activating the pelvic floor. Okay, so a simplistic view of the body doesn't accurately encompass the complexities of being human. So that an isolated area of the body can simply reduce its activity or increase its activity and everything will get better doesn't often play out. So it's got kind of out of balance because of a combination of kind of different things, and a combination of different professionals' advice and tweaks might help us to get on a sort of an upward spiral of feeling better. So a more holistic approach involving the body and mind, I feel, is a much better way to view and to go about rebalancing the body, including rebalancing the pelvic floor. So it's integrated, the pelvic floor is integrated with the whole body and the mind and the breath. And a segregated view of the body is kind of reinforced by our Western kind of health system, which separates body areas into specialties. For example, you go and see a gynecologist for any problem with your reproductive organs, an endocrinologist for any hormone problems, a psychiatrist for disorders of mood and thought. But the body and mind are complex, and the interactions cross over many body systems and therefore many sort of specialties. So symptoms are often eased by help from lots of different professions, and holistic therapies are likely to benefit. So I just wanted to show you this picture. Let's just go down. You can spot the mistake here. So where do we go for help? Where have some of you maybe already been for help? So this is just have a little read on that, just to see how awake are you this morning. Can you spot a little spelling mistake there somewhere? So yeah, I can see some of you. Oh yeah, okay. Spotted that at the bottom there, yeah. So obviously NHS, we have got a bit of a long wait nowadays to be seen. But talking of seeking help and having investigations to rule out anything sinister, maybe getting different opinions, tweaking our habits, trying medication, movement practices, which will introduce maybe less familiar patterns of movement to your nervous system. Things like maybe meditation, breathing exercises, even humming or singing may help. So we don't always kind of go straight sort of for the medical. Well, we may do, but we may eventually explore other things as well that might all be helpful on our journey. So I like analogies. I'm just going to move down again to the next screen. So this is an analogy of our body being like an orchestra. So the body can be viewed like an orchestra, and each area or muscle is like an instrument in the orchestra. So the orchestra knows what to do from previous practice, and of course is led by a conductor that is listening. So each area sort of fine tunes and blends with the rest of the orchestra to form a harmonious whole. So if you think of each muscle like an instrument in the orchestra, and each muscle needs to know how to play their parts, to play at the right volume, at the right time, and to be able to stop and also go to sleep, or to stop and switch off. And we see this kind of play out in our bodies with smooth, kind of efficient, pain-free movements. So if one instrument or one muscle is too loud, it might make others around it give up. Or if it isn't loud enough, others might try and make up for it. So to look after our own instruments or our muscles, tune into them, we need first of all to notice what they are doing and take them through full ranges of maybe movement, a bit like doing scales, to help guide them to switch off, to release, and to move our bodies in all the directions we've been evolved to, and that they're designed to move through, to rehearse patterns, a bit like an orchestra will have to rehearse something over and over again to get good and all interact with each other. So habits that have been learned are really difficult to shift because these ingrained patterns of activity have become familiar to our nervous system, to our conductor. We don't notice what our habits are. So it might be that somebody else who notices, who can kind of be like a second person tuning in, because your conductor might be selectively deaf or just not aware of kind of what sort of abnormal patterns might have become learnt. So another person who's kind of more trained in tuning into imbalances and so on might be helpful. So if you think about muscles and patterns of activity, they get sort of wired together. So what fires together in the body kind of wires together. So we can discover and bring to awareness where the patterns that aren't serving us well are. And what we can do is we can kind of confuse the muscles and get them to work differently if we take the body into maybe a different orientation to gravity, or as we might in an orchestra, just exercise one part in isolation, or with maybe a bit more support to that part. Muscles will fire differently in lots of by sort of tweaking things and tricking things in lots of different ways. So, for example, a muscle that really wants to kind of be too active, we might even go with that desire to kind of close that muscle down and to activate it more, in order then to learn and feel the opposite pattern of releasing it. So in the same way, we also need to learn to release muscles in order then that they can be graded and be able to sort of fully engage or work at various levels when we need them to. And as I said, some help might be needed to do this. But quite often the help that's needed is for your conductor, your attention to come online as to what's going on, to become a little more mindful and aware. So an integrated approach to pelvic floor health is what I'm passionate about. So having said that, please do take a little fidget. Maybe if you've crossed your legs, uncross them, cross them the other way around. Become aware of what have been your habits of kind of how you've held yourself or how you've positioned yourself so far. I know some of you with cameras off, you might even be walking around, you might even be attempting to multitask, I don't know. But I'm passionate about a more integrated approach to pelvic floor. And what I've learned in my experience so far, I've learned a lot from courses and reading and watching things online. But I've also learned a lot from my own body. And when it's gone wrong, I've learned most from my journey to find more ease. And what I've to share with you today is from my training as a women's health physio, which my postgrad training was about 20 years ago, was about a year training. I don't actually practice in sort of pure pelvic, the pelvic area at the moment. I'm practicing now in the NHS as a community physio. But what, obviously I've still got all the tools in my toolbox that I've acquired and learned. I probably estimate, so in my work at the moment in the NHS, in the community, seeing housebound people, I probably estimate that about 9 out of 10 of my patients who I see are probably under the bladder and bowel team as well, getting pads due to continence problems. So for many, as age advances, it's often the main reason they seek extra care or maybe go into some form of residential care as well. So it's kind of a really important area of the body. So as I said, I've learned most from my own embodied experience. I've been in my body for 51 years. I've had 2 children, both very different birth experiences. Despite my attempts at perineal massage, so everything would hopefully stretch beautifully, I ended up with an emergency cesarean and a ventouse delivery. And my recovery from those was kind of interesting. And more recently, I've experienced personally some pelvic pain, which actually needed a combined approach with a medication to help relax some of the more deep, smooth muscle, the involuntary muscle, in fact, of the internal anal sphincter, which was held and stuck involuntarily, kind of with tension. So I had cream to help release that in order to allow kind of healing and restore a kind of a normal pattern to be restored to the body. So I still get pain from time to time, kind of from this sort of weak spot. And yeah, so I'm kind of on a journey maybe with many of you in helping to discover, what can I do to help myself and what's been helpful in my journey to kind of understand how I can optimize healing and improve things. So what I do is I teach and I do self-practice in sort of mindful movement. So teach sort of Pilates evolved movement classes, but also influenced by other movement therapists such as Feldenkrais, yoga, and these sort of quieter, slower paced, really kind of tuned in, heightened awareness kind of movement practices have really helped me to discover movements, muscle release techniques, probably heightened obviously my body awareness, which has helped me look after me by learning to read my body signals so I can recognize not only my physical kind of well-being, but also my mental well-being as well. And this, obviously, any emotion is kind of felt in the body. So we can learn a lot maybe about our thresholds for kind of stress. And when we feel we're kind of reaching over, when we feel it in our bodies, and we can learn a little more about kind of, modifying so many factors maybe in our life to help us. So I'm on a journey to breathe, to learn to breathe. And I've actually found that singing, chanting, even drumming has kind of helped regulate my nervous system, which helps balance my personal body kind of orchestra, my body-mind orchestra. So I've got an interest in mental health, and managing and regulating my own mental health is a priority. And thankfully my work, so things like today, but actually my work more interacting with people in real space is probably what nourishes me most. So this is kind of a little out of my comfort zone this morning. But I have played with other movement-based therapies along the way. And they've been really, really helpful. And they include things like the Franklin method. So later on, I'm going to be demonstrating some muscle release techniques, which is kind of, you may have heard of the Franklin method. We use these sort of slightly squishy kind of balls to help release tension. So I've kind of played with that along the years. Other movement therapy, there's one called Continuum, which is a combination of wriggling around, moving, but vocalizing. So you create a sort of a deep vibration from your own sound and breath, combined with movement, which is I found really powerful. And also other movement-based therapies, more to do with regulating the nervous system, the mind. I've tried things like EMDR, eye movement, desensitization, reprogramming, and also another one called tension release exercise, or TRE. So there's so many different things. They're just the ones that I've kind of encountered and found helpful, but there's so many other things that maybe some of you have yourself, or you maybe haven't exhausted all the different things that might be out there to help. So today there's going to be some practical things that I'll invite you to participate in. The body learns by the experience of doing, so joining in, not passively listening or reading. So some of the things we experiment with today will hopefully be helpful and resonate with you and be part of your journey to find more ease and comfort. And some things might suit others, but not you. So please, it's your job to kind of tune in, especially because there's not much ability to interact and sort of watch other people. You've got to really tune into you, and things that don't suit you, don't feel helpful, might even trigger your pain, obviously don't do. So it's your job to listen to you and grow in your wisdom by learning to interpret your body signals, and to do what feels right for you today, but obviously also every day, so that you're kind of on a journey to being able to feel better and function better. So I thought we'd just do a little bit of sitting practice now. So I'm actually going to unscreen share, I think. Here we go. And just come onto my chair. So you might want me on speaker mode. I think if you maybe pop that on, hopefully I might be the biggest person on your screen. I'm actually going to pop it back on gallery mode because I like to see who's here. Okay, so come and sit on, have a sit. I know most of you are probably already sitting, but just sit in your chair. And I'm here to, oh, you'll also notice as I hobble across the floor, I'm kind of mending. I broke a little bone in my foot, yeah, it's kind of healing. So I'm kind of a little bit hobbly. Okay, so in sitting, what I'd like you to do is to fidget your bottoms. Uncross your legs if they're crossed, have a fidget. See if you can spread your bottom out in your seat. So you're sort of spreading your sit bones out a little wider and maybe walking your sit bones, I don't know, sort of towards the back of the chair. And just sense with your head balanced on top, do you feel fairly sort of centered, fairly aligned with your head balanced in the center? Now, if you lean back towards your backrest, notice your head kind of moves forward in space. I'll just sort of show you maybe on me. Your head rolls forward in space. You're a little bit closer to or more on your tail. And a lot of chairs, including the one I'm on, is kind of encouraging me towards the backrest, so a little downward slope towards the back. So in fact, a more kind of balanced sitting posture for your pelvic floor is to often sit away from the backrest and just sort of perch as if you're sitting kind of on a bench. But the body likes variety more than anything else. So as I go through, especially I'm going to talk a little bit through physiotherapy pelvic floor assessment and what that involves. So I'm going to be talking for a bit longer. Please do fidget and explore. So what I'd just like you to do now in sitting, just going to change my camera angle slightly, is to look down into your lap. Look down and notice that your sit bones draw together a little bit more. You kind of close down a little at the back of your pelvic floor. And as you look up, maybe feel that your pelvis or even your trousers stretch, widens a little bit. So you feel your pelvis closing down a little at the back and opening up a little at the back. Yeah, and you can adjust and fidget your weight continually. Even though at school we were told not to fidget, fidgeting is really key to health, to finding more comfort. So fidget and just, yeah, sense how that is. So I'm going to invite you to, in fact, stand up now and have what I call a little shiggle around. This is especially good for releasing your tail. If you maybe you're in a wheelchair or standing is an option, you can kind of do a version of it in sitting. So just have a little shake out of your hands, of your knees, of your tail. And when you shake your knees out, you have to release the tail area. So that image of the dog we had on the screen earlier with its tail a little tucked, its tail wouldn't have been moving much. It was a little frozen, wasn't it, in fear. So when we shake our knees out, shake our tail out, shake our hands, wrists, knees out, we kind of allow that release. And then with a softness to your knees, have a sense of heavy, I don't care arms. So arms that sort of just bash against you, turn and look over each shoulder, have a little look behind you, yeah? And notice as you bring your head to look over your shoulder, your head becomes in balance and more balanced over your body. And when your head is in balance, so is your pelvis and pelvic floor. Great, so I'm going to talk to you a little bit more about anatomy. So if you want to get a little closer to your screens again, come and have a sit down. But please, throughout the class, fidget and come to sort of tuning in and noticing. So I'm going to share the screen again and find the next few slides. So, here we go. So, oh yeah, that was the other thing I was going to say about my knowledge. Oh, hang on, let's get the right image up. Here we go. So my knowledge and experience is limited, but I hope, as I said, that you learn something and maybe practice some of the techniques that you find helpful. And obviously, there are plenty of other things which you can trial, people you can speak to more specifically, maybe about your problems. It's difficult because we've all got different issues. So there's going to be different courses, different organizations and places like Chronically Awesome, other sources of information on the internet, self-help groups, that sort of thing, support groups, where there's sharing. And one of the things that I hope you maintain is an optimism, to stay curious and to keep looking and experimenting to find the right help. So the body is always looking for more ease, and the word dis-ease or without ease is the opposite to ease. So when the body finds something better, it will often seek it out again and maybe hold on to a sort of different pattern or a new habit. And it will all be part of a kind of a journey to help you find ways to help yourself. And that's quite empowering to know that there's things that you can do. So my remit, what's the pelvic floor? How does it work? A bit more on what causes it to be out of balance and what we can do to ease symptoms. So first we're going to talk through the bones of the pelvis. So just going to bring the screen down. Okay, so at this point, as you sit, I want you to feel the bones on you, because it's all very well looking at a picture, but so what I'd like you to do is to just got to spotlight my pelvis. I'm actually sitting on a very low chair, but anyway, what I'd like you to do is to feel the crest of your pelvis here at the top. As you're tracing the iliac crest here, feel around the back. There's this broad flat bone called the sacrum, which terminates in the coccyx or tailbone. In fact, I encourage you maybe to sit forward so you can feel up where your tailbone is. Hopefully we've not got an audience there. And then feel at the front where your pubic bone is, maybe the top of the pubic bone, down at the bottom of the pubic bone. Yeah, and yeah, you can stand and feel a little bit better. Some of you may be wanting to stand up and have a feel of where your sit bones are. So you can either trace from your tailbone downwards towards the sit bones, or you can just fold forwards and sort of feel where those bony prominences are there. Yeah, they're called the ischial tuberosities, or simply your sit bones. And you can see from this picture here where your hip joints are. They're a little bit more to the front than people often think. So as you sit, or if you stand, if you kind of reach into the groin area here at the front, this is kind of where the front of your hip joint is oriented. And in lay terms, we often talk about sitting a child on our hip and our hip being kind of up here, but in fact, the articulating part is much lower down here and to the front. So they are your pelvic bones. The pelvis, the word pelvis is actually come from the word the basin. It describes a basin or a bowl that holds the organs kind of in place. So the pelvic floor fills the gap of the pelvic outlet at the bottom. It isn't a flat floor, although it's one of the few muscles like the diaphragm, like the breathing muscle, that's oriented kind of in a horizontal plane. And it is sometimes referred to as the pelvic diaphragm. So I'm just going to come down and here we go. Okay, so the pelvic floor is sort of funnel shaped, but instead of one gap or hiatus, we've got two gaps, one more to the front and one more to the back, same in men and women. Just going back to it being referred to as a pelvic diaphragm, it really interacts with our diaphragm, our breathing muscle, in such a way that breath work and breathing is likely to help heal the pelvic floor, especially an overactive pelvic floor. So we're going to be practicing later on some exercises that involve the breath and tuning into the whole relationship of the breath and the pelvic floor. So the two gaps at the bottom, there's a urogenital gap, or the one at the front, which the urethra passes through in men. So I'm just going to move down now to some images of the pelvic floor. So you've got kind of half of the male, but this shows you the urogenital triangle at the front. Also there's a space or a rectal hiatus or space at the back. And this rectal hiatus allows for the anal canal to pass. And between the two gaps is the fibrous perineal body, which you can kind of see quite well there in the female anatomy picture. And you can kind of make out that the pelvic floor muscles are sort of diamond shaped, with a triangle at the front being the front urogenital triangle, and the triangle at the back, or kind of the anorectal kind of area at the back. So the perineum is divided by a theoretical line between the two sit bones, and you can see the muscles kind of where the perineal body, or that white area, is just in front of the anus there. You can see the two muscles that kind of come out to the side. They attach onto the sit bones, yeah? And so that almost forms a line that kind of theoretically separates the front triangle of the pelvic floor with the back triangle of the pelvic floor. And the urogenital triangle, the front triangle, the muscles in this front triangle are a little bit more complex, with a number of fascial layers. So unlike the anal triangle, it has a layer of strong, deep fascia called the perineal membrane. So that's in the front triangle. So just kind of going into a little bit more anatomy now. So the perineal body is at the junction of the two triangles, the middle of the perineum, and it contains skeletal muscle, smooth muscle, which is involuntary muscle, but also elastic fibers as well. It acts as an attachment point for the muscles, this sort of perineal, this fibrous body in the middle. And in women, it acts as a tear-resistant body between the vagina and the external anal sphincter. And it supports the back wall of the vagina against prolapse, or the bowel kind of dropping forwards into that back wall of the vagina. And in men, the perineal body lies between the penis and the anus. Yeah. So The major nerve supply that supplies the pelvic floor is called the pudendal nerve. It arises from the nerve root S234. And I remember having to rely on sort of little sort of poems and things to remember. So we always would say S234 keeps your bum off the floor. So the clinical relevance of the perineal body, it is, so in childbirth, it can lead to stretching of the perineal body, thus leading to compromised support. And this stretching of the perineal body, or the sort of more fibrous kind of fascial layers, is avoided by an episiotomy, which is a cut into the muscles performed often by the midwife, and it prevents uncontrolled tearing of the perineal body. And I've just got a little example there, a picture here showing that's the diagrammatic version here of the, I'm pointing at it, that's not helpful, is it, for all of you? We've got the two theoretical triangles, or the diamond shape of your pelvic floor there. And I'm kind of creating it with my hands here in front. But this is just the picture I wanted to show you next, which is just showing the baby's head kind of bulging from the vagina, and where the cut might be the left lateral, medial lateral cut, to help preserve any tearing towards the external anal sphincter. It sort of disrupts the vaginal wall a bit, but that heals much better than the muscles. So just interestingly, some of you may have had children, so the ideal kind of stretch time for the pelvic floor is about an hour. So the second stage of labour ideally would be about an hour, which gives the soft tissues sort of a nice slow time to sort of stretch without damage, but not so quick that they stretch and sort of overstretch and tear. And some people may experience a quicker second stage or a more prolonged second stage, which might be associated with more stretch damage to the soft tissues, and perhaps stretch damage to this pudendal nerve, this nerve that supplies the muscles as well. So interestingly, any nerve stretch damage, which is very likely to occur in all deliveries, it normally takes about 3 months to kind of to repair. So nerves take a little bit of time, any stretch damage to repair, but that's the sort of time frame that we'd normally suggest to women after birth if they're experiencing problems, that the nerve stretch damage takes to repair. So just going back to this picture of the diamond, what I'd like you to do now, have a fidget in your chair again, or have a stand up and a stretch out, have a shiggle again, shake out. I call it a shiggle. It's kind of a cross between a shiver and a wiggle, and I kind of get people sometimes to do that just to break any fixed tension patterns they might hold. So what I'm going to get you to do with your hands, I'll show you with my hands, is to make this diamond shape with your own fingers. So you can do it in standing if you want. So your index fingers represent where your pubic bone is at the front. Your thumbs touching represents where your coccyx or tailbone is at the back. And the two sort of bits at the side here represent where your sit bones are on each side. And classically, the pelvic floor muscle is a little bit out of balance in that the back triangle is a little bit held in too much tension in relation to the front. And it's commonly why we see problems of leaking, which obviously comes from the front triangle. The problem is from the front triangle, and prolapse again will come from a sort of a weaker, more stretched front part when the back part is kind of held fixed and closed. Any sort of coughing or sneezing or bearing down force tends to stretch and sort of release and weaken more the front triangle. So quite often in restoring optimal pelvic floor balance, we're releasing a little bit more in the back triangle, which is what we're going to be focusing our attention on today. So another area near the female is going to move back up to the female reproductive organs. So another area in females of interest is somewhere called the superficial pouch, which is kind of close to the surface in the front triangle. And in this area is something called the Bartholin glands. And the role of these glands is to make a small amount of mucus-like fluid And if these ducts become blocked, these glands can swell and become fluid-filled cysts, and these cysts can become infected and inflamed. And the most common cause of this inflammation is a bacterial infection. So I'm now going to come down and show you, so there we go, the pelvic floor muscles kind of, and there's plenty of diagrams and so on online if you want to look more closely, and also some really brilliant kind of 3D animations as well, which help us to kind of understand a little bit more the different layers of the muscle. But this little diagram shows you the angle of the organs inside. It is a female with the uterus in there. But when the pelvic floor muscles, which attach to the pubic bone at the front, which is that kind of grey circle in front of the bladder, they wrap like a kind of a sling, if you like, and attach onto the coccyx, which is illustrated with the C at the back, their tailbone. So when the pelvic floor muscles are kind of engaged at their resting level, the angle of the anorectum, you can see there at the back in front of the tailbone, you can see the brown area that illustrates the rectum, and there's that angle at the end, the anorectal angle, where the rectum becomes the anus. At rest, the pelvic floor holds the anorectum closed. Its resting angle is about 80 degrees, so it stops things dropping down or coming out when we don't want them to. It's when we release the pelvic floor that anorectal angle widens and things can empty far more easily. Interestingly as well, with the bladder, the angle of the bladder neck changes with pelvic floor activation. And I've been fortunate enough to have some real-time ultrasound of my perineum. So you can kind of make out on a screen what the organs do, how they change their position when you engage your pelvic floor and when you release it. So that's just one of the tools that us as women's health physios might use. We use real-time ultrasound so that people can see for themselves what happens when their muscles engage and when they release. Okay, so the pelvic floor, so when the pelvic floor descends, the puborectalis muscle, I'm pretty sure I've got a picture here at the end, so I'm just whizzing through here. Okay, so I'm just going to show you this little diagram. We'll come back to it a bit later on, but it's another diagram of the pelvis. This time it's kind of switched the other way around, so sorry about that. But it illustrates quite nicely how one of the pelvic floor muscles, it's called the puborectalis, attaches to the pubic bone at the front, where it's illustrated here on the diagram PS. It loops around the back of the rectum, and that's the muscle that holds the rectum at that 80-degree angle. And when we release the pelvic floor, it releases its hold on the rectum, and that angle kind of opens up to allow gravity-assisted easy release of stool out of the body. And this also, you might have noticed sort of danger times when we're more likely to release gas or have an urge to sort of empty the bowel. So it's this angle of the anorectum is also increased when the hips are folded more kind of fully, when you bring your knees up, when you squat. So you might have noticed danger times for releasing wind, things like getting up out of a low sofa, squatting down. But we use this knowledge to help re-educate and advise people in maybe optimal positions for emptying the bowel, which I'll talk about later on. Okay, so, well, in fact, or shall I talk about, I'll talk about it now, I think. So I'm just going to stop screen sharing and come back to sit on my chair so that I can just show you the things. I think I may forget otherwise. So this is something called the Squatty potty step, which kind of makes our Western toilets a little bit more like how people toilet in other parts of the world. It creates a little bit more of a squatting type position. So men tend to have learned from a young age a different way of emptying their bowel, because they've got willies, they've got to put them down into the toilet when they sit on the toilet. So they tend to naturally lean forwards like this and have learned that pattern from a young age. Whereas us women, we probably can't touch the floor a little, and we're kind of holding on, and we're kind of not really relaxed. The pelvic floor isn't relaxed, therefore we may not have that maximal release at the anorectal angle. So some of the habits of how we release have begun obviously from a young age. So how we can improve our positioning, maybe to get something like this Squatty potty step, which are available on Amazon. You rest your feet up onto it, which creates a little bit more of a fold, a sort of a leaning forwards. And in this position, it's a lot more kind of open, gravity assisted, in the bowel will empty kind of a little more easily. And obviously, if there isn't anything like that to hand, you can just simply lean more forward. So maybe practice now. I know you're sitting on your chair, you're hopefully not going to have a bowel movement where you are, but notice the different feeling as you fold, and maybe, feel the difference of that opening, certainly in the back triangle, and the pelvic floor may be able to descend a little bit more for optimal release, which obviously is required to empty bladder and bowel, but especially kind of the bowel. So we're going to practice a little bit more some kind of squatting type positions. Whilst I've still got you, I'm not sort of the screen share, I just wanted to show you this, which is a prop I use to visualize the pelvic floor. Here again. Okay, so this basically illustrates how the pelvis isn't a rigid structure. Obviously, we saw those joints earlier. We've got the pubic symphysis, there's a little bit of movement there at the front of the pelvis. We've got the joints, the sacroiliac joint at the back, and the pelvic floor underneath, which is kind of elastically designed to move with us, so that when we bend, we get the pelvis kind of expanding and closing down. So I don't know if you can see what I'm doing here with this, but as we bend, what happens is the sit bones release and widen. So as I bend, I feel my trousers under a stretch, and as I stand up, I feel everything kind of spring back and come back to a normal place. So this idea of the pelvis and pelvic floor expanding and releasing back, being kind of able to move in those two directions. So sometimes it's quite nice to have these little imagery things to sort of visualize what's going on. Okay, so that's probably enough about the bowel and so on. So how does it work? So I'm going to come back to my screen share again and find the right bit. Here we go. Okay. So sometimes, as I was suggesting earlier with regard delivery, if maybe the nerves have got a little bit stretched and damaged, we might have an abnormal tone maybe on one side, maybe reduced tone. If we've got some kind of neurological condition, something like cerebral palsy, multiple sclerosis, Parkinson's, head injury, we might have a neurological problem affecting our muscles. But when the muscles are working optimally, they support the base or the core of the body, allowing us a full repertoire of movement. And that's it, especially pelvic floor, influencing the trunk, the hips, the spine. And obviously the pelvic floor importantly holds on to urine and feces and wind until it's convenient to empty. Having said that, 1 in 3 women and maybe 1 in 12 men have some kind of problem with the pelvic floor, with either bladder bowel control or prolapse. So things like hormones are going on now. I know somebody at the beginning requested talking about hormones. So the normal balance of sort of estrogen and progesterone helps to maintain healthy pelvic floor. And during the week before a period and the week of your period, the estrogen levels drop, the pelvic floor becomes a little less kind of strong, a little less maybe stretchy as well. So if there is a vulnerability there or a slight problem, people might experience a problem during that time in the month. And maybe women don't notice problems until postmenopausally. And I liken estrogen to the pelvic floor, kind of a bit like, I don't know, it sounds simplistic, but oil of Ulay or something like that. Something that helps to keep the muscles soft, stretchy, elastic, and kind of but the main thing is it helps the muscles to sort of fire in an optimal way as well. So maybe postmenopausally, if you can and you want to try hormone replacement therapy, either systemic hormone replacement therapy, or some women prefer just to use vaginal estrogen cream or vaginal estrogen pessaries, which are very much absorbed just locally to the pelvic floor area, that have an effect in sort of boosting that area and helping if you're having sort of symptoms for the first time of either prolapse or leaking, or maybe urgency or frequency. It could well be certainly that the hormones will play a really important role in helping to improve the functioning of the support to the bladder. So the other thing is that aging affects the pelvic floor muscles. So normally the ratio in our pelvic floor is that, so in all of our muscles of our body, the orchestra, if you like, the analogy of the orchestra, different muscles have different functions. So for example, our pelvic floor muscles, there is 80% slow twitch or postural muscle fibers, and 20% more kind of phasic fast twitch muscle fibers. Similar proportion maybe to that in the neck, and the neck's holding the head up all the time without us knowing about it. So similarly in the pelvic floor, we don't have much awareness of what's going on. They're just kind of doing their own thing without us being aware. So what happens with age is that globally in our bodies, we tend to lose more of the phasic muscles, the fast twitch fibers, and we get more slow twitch muscle fibers kind of converted. So we can exercise a little bit more the pelvic floor to sort of awaken the faster twitch muscle fibers of the pelvic floor, but also the hormone side of things has a really kind of accelerating effect, if you like, on the change in the muscles. So the other sort of things that might compromise your pelvic floor, childbirth. Obviously, I've showed you the picture there of the episiotomy. The pelvic floor is designed to kind of stretch, but if you have more than 4 vaginal deliveries or 4 births, your incidence of problems might be increased. And pelvic floor isn't preserved by having a cesarean. So there's some stretch and changes in the pelvic floor that occur just from pregnancy. So other things also compromise your pelvic floor: chronic straining, for example, from constipation from straining on the toilet, coughing, if you have asthma, COPD, something like that, lifting unaccustomed heavy weight as well can also have an effect. So what causes it to be out of balance, and how can we rebalance it? So addressing the hormonal changes, as I've suggested. There's some medications as well, which can influence the activity to the bladder muscle itself, the smooth muscle of the bladder, which can help calm things down. That's called anticholinergic medication. Some people, if they've got a very overactive bladder, might even have something like Botox infiltrated into the bladder to prevent your bladder being sort of overactive, misbehaving, and so on. One of the other main things to sort of rebalance things is improving, maybe re-educating bowel habits, bladder habits. And if you go for an assessment, all of those sort of questions are asked. So what I thought my remit could be, or would be worth sharing with you, is what would be the physio role, and how do we assess and treat pelvic floor and pelvic pain? So the first, let me just come back here. Oh, sorry, I've got here, so you can have a little look at that. So I'm just talking here about the different things that compromise it, so have a little read of that. So going to the physiotherapy role, I focused it on women, but many women's health physios also treat men as well. So an assessment classically is at least an hour, or possibly longer. And there's plenty of time for the patient to tell you their story, to tell you what's going on, i.e. the location, the duration, the nature, the intensity of the symptoms is recorded. And we use diagrams, detailed diagrams of the perineum to record exact pain locations and pain intensity. So everything is recorded. We often use a visual analog score of pain, a 0 to 10, maybe a quality of life measure as well. So a little questionnaire, questions about dyspareunia or painful intercourse. So questions like the frequency of sexual interaction. And obviously this varies very widely amongst the population. There's no normal kind of frequency, but commonly with people with experiencing pelvic pain, there may well be a lack of desire, limited arousal. They're common problems with pelvic pain patients. Women with primary dyspareunia or painful intercourse may have never had pain-free intercourse. So depression, we ask questions about that. It's not surprising that chronic pain and sexual dysfunction are 2 risk factors for depression. So we'll ask specific questions about sexual abuse. I'd normally address the questions such as, has anyone ever done anything to you that you did not want to happen? And that might bring about people sharing what's happened to them. Sexual abuse is a common finding in many pelvic pain patients. They may disclose their history of sexual abuse, and your treatment as a physio will be modified, for example, keeping in mind what might trigger them. I drove past the other day. We've got a charity in the area I live, Survivors in Transition, and I just saw on the wall that sexual abuse is sort of more common than you might think. 1 in 4 women and 1 in 6 men, and quite often, even if nothing's shared, the nature of progress sort of with your sort of treatment, they often progress quite slowly, and a referral to psychosexual counselling might also be discussed with the patient if appropriate. So we'd ask specific questions about painful intercourse, whether it's pain on penetration, which is the classification of vaginismus, or whether it's more sort of deep penetration. So penetration pain is usually associated with interrotal scars, episiotomy, vaginal surgery, or maybe lesions on the skin outside, something like a Bartholin cyst, or external irritation such as thrush, whereas deep pain is more related to pelvic floor muscle spasm or organ dysfunction, so such as, I don't know, interstitial cystitis. There's lots of various different conditions. So we ask questions about pain. How long does it last? A simple scale of the pain and how long it lasts. And then a simple scale of sexual function as well. It might be that 0 is no pain, no limitation with regard sexual function. 1 would be some pain with intercourse, but no limitation of frequency or sexual activity. 2 might be significant pain with intercourse and limitation in frequency. And 3 on the scale would be severe pain and inability to tolerate any penetration. So we'd also ask questions regarding achieving orgasm. Does it increase pain? Orgasm, incidentally, is a very complex kind of thing. It feels great, and obviously it has a purpose too. In that during orgasm in females, the purpose is that the rhythmic contractions of the pelvic floor help to draw semen up towards maybe the awaiting egg. And pain with orgasm might indicate pelvic floor spasm. Lack of orgasm might indicate pelvic floor weakness. But there are many, many reasons for pain with orgasm, and many reasons that some women are unable to orgasm. So as part of a physio evaluation, we'd also ask obstetric history. So children, have you had children? What were the birth stories? We'd ask about bladder emptying, bowel emptying. Incidentally, there's quite a big range of normal, but we'd say normally the bladder would empty about 7 times, 7 or 8 times in a 24-hour period. Normal possibly to get up once at night. And if frequency is outside of that, we might advise doing a fluid volume chart or a bladder diary. With regard bowel emptying, there's a more bigger range of normal. There's a more variation. So anything between emptying once a day to once every 4 days, or 4 times a day. Yeah, so there's more of a sort of a range, sort of what's normal for that person, and if has there been any change, would be what we're kind of asking for. Okay, so yeah, that's it. Oh, with regard the urinary side of things as well, we'd ask about flow rates. Does the flow start straight away? Is there hesitancy? Does it stop-start, and so on? And maybe we'd refer on to other people, possibly for some urodynamic studies where they look more closely at the bladder function. So objectively, or what do we observe? What do we look for? What do we feel? And what do we see? So I start looking at people from the minute they come in, or when you invite them out from the waiting room, you're watching, how do they walk? How do they move? How do they get out the chair? We'll look at their posture, their sort of normal habitual postures, and the pelvic inclination. How do they sit? Do they sit more on one side? Do they stand more on one leg? All of these things might lead us to, in our observing different sort of joints and different, looking at sort of more of a musculoskeletal assessment for the pelvic area. So say, for example, somebody stands more on one side than the other, there could be some torsional loading through the sacroiliac joint, or a little bit of torsion that affects the pubic symphysis, the pain in the pubis at the front. So as part of the first assessment, you'd be checking muscle length in patients, so calf muscles, muscles around the hip, quadratus labrum, deep back muscles, abdominal muscles, range of movement, muscles around the hip, inner thighs, gluteal muscles, and so on. And we'd always seek informed consent for a digital vaginal examination, possibly a rectal examination, and in men we assess the pelvic floor sort of rectally. So before you kind of delve into the little orifices there, you'd have a look on the outside at the perineum and at the vulva. You're checking for redness, swelling, discharge, and for the sensitivity of pressure and light touch. So sensory testing in the saddle area, which I'm just going to sort of stand up. In fact, you might all want to have a little stand up, stretch your legs. So obviously the saddle area is the perineum and the inner thighs here. So sensory testing to that saddle area, we're looking at the dermatomes, the sensory innervation to the same muscles. We compare the right side with the left side. We test for reflexes as well, assessing the opening to the vagina. So a little sort of cotton swab test. So you use a little moistened cotton tip and you assess pain at the introitus, at the very opening to the vagina, and you apply pressure at various points. And obviously sort of palpation. So careful palpation or feeling around the pelvis and the trunk. The joints are also assessed, and soft tissue palpation also includes muscles and their associated tendons and fascia, including skin and any scars as well. So going back now to the pelvic floor is examined internally, vaginally, to assess muscle length and strength and coordinated firing during a pelvic floor muscle contraction. And palpation is also used to find trigger points or areas of exquisite tenderness and pain. So abdominal palpations are over the belly. It requires knowledge of visceral anatomy or the position of the organs inside. And with training, a therapist can develop the ability to assess organ position, motility and mobility. And there's a test called the Carnet's test, which is used to differentiate between abdominal wall pain with organ pain. And by palpating the abdominal wall, this is with the patient laying with their knees bent up, So what you do is you palpate the abdominal wall with or without a head lift, a head and shoulder lift. So if pain decreases when the abdominal muscles are tensed, this indicates that the viscera or the organs are more likely the source of the pain, as the abdominal muscles are now protecting the organs from the examining pressure. So we also feel for sort of deeper muscles. There's this muscle called psoas, which is very deep, almost the other side of the organs, but that can also be carefully palpated with care not to squash the organs overlying it. So any suspicious sort of lumps or bumps would always be reported to a doctor, and maybe obviously people might go on for further tests like ultrasound or laparoscopy, or cameras, various cameras to sort of see what's going on. So if somebody doesn't want to consent to an internal examination, that's absolutely fine. You just adapt your assessment around assessing more externally and palpating a little bit, maybe around the perineum and the belly. So treatment of pelvic pain. So I'm just going to move my slides down a little. Okay, so careful evaluation is done from the examination findings, and the treatment, the key to successful outcomes for physio for the patient is a good sort of therapeutic plan with specific goals based on the findings. And as therapists, we always remember that treating pelvic floor muscle dysfunction in isolation without addressing other musculoskeletal or pelvic imbalances will probably be ineffective. So we're kind of looking at the whole, if you like. So patient education, stress management, therapeutic exercises, manual treatment, so that sort of thing. Also, adherence and compliance with your patient is influenced strongly by your patient-therapist relationship, and helping the patient to understand the purpose of each of the things you're suggesting can really help them obviously comply and understand what's going on. So also your patient's expectations are discussed and corrected if they're not kind of realistic to what your experience and what your findings have been. So posture and body mechanics, so interventions aimed at posture impairments in pelvic pain patients have been reported to be successful. So there's various sort of studies. I didn't want to start citing lots of studies, but looking at posture is huge, and how the breath interrelates with that is huge in helping people find more ease and more comfort in their pelvis and any pelvic tension. So prolonged sitting often increases coccyx pain. So posture education, if you've got coccyx pain, you'd avoid chairs with excessive cushioning, and also chairs that are too hard as well. Donut cushions, they actually increase the pressure on the coccyx, but sometimes you might use a donut cushion if somebody's got a sore perineum after delivery. Cushions that might be more appropriate for somebody with coccyx pain might be a wedge-shaped cushion with a little cutout at the back, which helps to increase the forward tilt in the pelvis and relieve pressure on the coccyx area. So vulvodynia, I know somebody said about asking about vulvodynia. These patients typically don't benefit from any from any special type of cushion, but all people will benefit from changing positions frequently. So with regard to therapeutic exercise, so we often encourage people to do some form of exercise that's kind of cardiovascular, it's enjoyable to them. And interestingly, simply walking can be helpful to decrease pain for people with pelvic floor muscle spasm and vulvodynia. Swimming is usually suitable for most chronic pelvic pain, but that the chlorine in the water might exacerbate somebody with sort of vulvodynia, which is often more kind of pain associated with kind of more irritation, kind of superficially, I guess. So you've obviously got to be careful, kind of what you suggest, and go with what that person finds suits them or doesn't suit them. So soft tissue mobilization, there's techniques of myofascia, and this is another reason I've got this picture up, showing that through trigger point release. So this is quite often performed rectally in women and men, to find the various muscles, like the Pubo rectalis muscle might have some exquisite areas of sort of tenderness or bands of tightness. So somebody really skilled in soft tissue awareness and myofascial awareness will use different techniques to kind of stretch, and they'll work very much with the patient, getting them to kind of contract and relax as they're treating, in order to influence and change some of these patterns of tension in the pelvic floor. And although this might be quite uncomfortable, often it's reported that people who have had decades of pain, after just 2 or 3 sessions, get significant relief. So it may be something that you can look into with regard finding a pelvic floor physio who specializes in pelvic pain and internal work. So the connective tissue system, I kind of thought I'd better explain a little bit more about how the anatomy is. It includes the ground substance, elastin, collagen, bone, cartilage, and adipose or fat tissue. So the connective tissue houses blood and lymph vessels and nerve bundles. And the connective tissue or fascia spreads in a 3-dimensional web throughout the body, so that every muscle, bone, organ, nerve, and vessel is wrapped in fascia. And the purpose of this fascia is to sort of separate structures, to support structures, to bind and to nourish structures as well. So the treatment of fascial restrictions is essential to restore kind of pain-free function in the body. So a massage of these levator ani muscles and the coccygeus muscles via the rectum, just to tell you a little bit more, it kind of involves rubbing the muscle fibers from the origin to the insertion and repeating the technique often 10 or 15 times. It's modified according to the location of specific restrictions, and the concept is to treat according to the specific layer of tissue restriction and the direction that the tissue is restricted in. So what you do is you kind of compress and evaluate where the dysfunction is, where the depth of dysfunction is, and if the dysfunction is noticed by a restriction of fascial movement. So sometimes the dysfunction is noted, and it might not always be painful, but sometimes a restriction can be found and can be worked on. Pain isn't always the guide, is what I was sort of saying. So there's a precise depth, direction, angle to take the dysfunctional tissue to the end of range. So a good therapist has really got kind of listening hands. They're noticing, they're getting the patient actively involved in kind of relaxing, breathing throughout the treatment. And the patient can then assist the treatment with the conscious relaxation and the contract relax of the pelvic floor muscles, with sort of plenty of verbal feedback. So patients or people that have got adhered episiotomy scars, they're kind of stuck down areas, or abdominal scars that got stuck down, can be taught soft tissue mobilizations to improve scar mobility. And sometimes we use sort of different devices, something like dilators might be suggested to be used for patients to sort of self-practice at home. So modalities to treat pelvic floor spasm might include heat, cold, ultrasound, TENS machines, neuromuscular electrical stimulation. So we've got all these different modalities that help affect the soft tissues, that can be used in conjunction to help soothe tissues, maybe after treatment, or prepare tissues before treatment. So some of you might have used TENS machine in the past. So classically, often women might use TENS to help with labor pain. We can position the electrodes of a TENS machine over the sacrum at the back in order to help with perineal pain, because those nerve roots correlate with the pelvic floor. So that can also help. And also rectal stimulation. We use a frequency of about 20 hertz has been found to be effective in reducing pain in male patients with chronic pelvic pain. So another modality which I talked about briefly earlier, which I had tried, was the real-time ultrasound. There's other forms of biofeedback called EMG or electromyographic, where you can see on a graph through a probe what the muscles are doing, and by looking at a screen at the graph you can kind of reconnect the brain with the bottom and learn to release various areas of tension and learn kind of what to do. And quite often the EMG machines pick up tension that can't be kind of that the patient isn't aware of, and even the therapist isn't aware of, and it's especially true in women, as the nerve input's often disrupted a bit after childbirth to the pelvic floor. So what we often term as our pelvic floor therapy is kind of down training or releasing. Teaching a muscle to relax is often more difficult than teaching it to contract, as the feeling of relaxation is more subtle and takes a lot of time, a lot of attention, and maybe something that you won't feel today as we practice together, but might be something that you quietly get to become more aware of as you do self-practice. And one of the main techniques is called the sniff, flop, and drop, which is a technique that was kind of coined by this amazing physio. I've seen her speak. Her name is Maeve Whelan. She's an Irish physio. She has an amazing website called pelvicphysiotherapy.com, where you can get the leaflets and instructions, but using a combination of the breath to encourage the pelvic floor to release is really key in a beginning of getting the body orchestra, getting the pelvic floor orchestra kind of at a starting point where you're ready then to start activating and so on. So we always teach release, even if somebody presents kind of with what seems a weak pelvic floor. It's hard to kind of classify or to explain, but quite often a weak pelvic floor is probably just an out of balance pelvic floor, that some areas are probably too tight. So we'd always start with the release, and after a pelvic floor contraction, practicing a contraction, we'd finish with sort of a release as well, just to bring the pelvic floor back to that baseline level. So we're going to use some visualizations and some various techniques. I'm going to stop sharing my screen now. Oh, sorry, here we go. So the down training methods here, I could have done with a helper really to help with my slides. But anyway, so the sniff, flop, and drop is kind of one of the main techniques that I'll show you now. Just to say also here before I turn the slides off, that chronic pelvic pain, as I've alluded, has a variety of causes, and it's always multifactorial. Therefore, a multi-pronged approach to helping will improve your quality of life, and a kind of a sense of, I don't know, optimism and curiosity to keep looking for different things. So I'm just going to stop sharing now and come to to be here. So basically what I thought we'd do is in standing, feel the different bones again, and then explore this sort of pelvic triangle, this pelvic diamond, and explore the two sort of triangles, the back triangle, the front triangle. And I'll demonstrate maybe with a few positions of the body why we often get short and tight around the front. In fact, before I forget, I just want to show you this book. It's called The New Rules of Posture, written by a lady called Mary Bond, an American lady. It's a wonderful book encompassing the breath, the mind, the pelvic floor, habitual everyday postures, and it's a really good sort of starting point or a really good reference point. You can see I've got all sorts of kind of things in there to sort of help you to understand maybe what some of your postural habits are and how they have an impact on your pelvis and maybe your pelvic pain. So let's stand up and have a little shake out. Shake out your knees again, shake out your tails again. We've been sat for fair time. So have a good old shake out your knees, tail, and just bring your head nicely to balance on top. And what I'm going to get you to do is to look down towards your feet and then to look up toward the ceiling. And let's bring in a bit of a yawn stretch with that. You can make the movement smaller or bigger. And obviously you can do this in sitting if you would prefer. Yeah. So in sitting, we just notice our connection with the chair through our pelvis. In standing, we notice the connection through our feet and how that flows up into our pelvis. So we look down as we bring our arms down, we look up as we bring our eyes up, and notice as you look down, you tend to shift a little more to your heels, you tend to tighten up maybe around that back triangle, feel a bit of tail tuck. As you look up and lift up, you maybe notice you feel your tail lift up, and a little more openness there around the chest. Yeah, so the contrast, and often if we're in pain, we adopt these postures of guarding, back on our heels, tail tucked. So much of our daily lives involves looking down, whether we're washing up, ironing, looking at our phone. So we're often practicing this tail tuck is kind of a predominant pattern. So a lot of what we need to do is to get our bodies to feel something different in that area. So when we move in a very wide repertoire in our lives, practice some kind of movement based, exercise that we enjoy, we can then sense that, when we look up, we feel our tail lift out, we feel a release there around the back. So finding some kind of movement practices with a teacher that you like that brings a very much wider repertoire of movement is key. But let's just, in sitting now, think about how can we adjust our seat in the chair to open up a bit more space between these two sit bones. If you bring your hands around to feel your sit bones, just tune into where they are. And you can sort of squash your fingers a little bit. But notice if you sit on your sit bones, you're not actually sitting on your tail. You're sort of more sitting in the middle, in that sort of perineal, in the center of the diamond, between the two sit bones, and notice what happens when you cross your legs. And obviously we've all probably been sitting here crossing legs and changing, shifting around, but when we cross legs, we maybe feel, okay, my legs are crossed, but feel the wonkiness at the sit bones. One sit bone is drawn a little further forward, everything is compensating above. And then if you uncross your legs but don't adjust your pelvis, you feel wonky or out of balance. So adjust and maybe try crossing the other leg. So quite often we have a favourite leg that we cross. So simply trying to cross your legs more evenly is another way of achieving more balance in your pelvic floor. But maybe bringing to your attention that actually just sitting and being in one position is what's prolonging or may have even caused our problems in the first place. So trying to adopt different positions, not sitting as much. So what I thought I'd show you then now in standing is different examples. So hopefully if I'm on speaker view, you can kind of see me. So if I was standing here and doing something like washing up, so I might sense after a while, I was like, oh yes, I'm kind of thinking, I'm maybe, multitask, obviously washing up something in my movement repertoire. So I'm thinking of other things. I'm not so aware that, I'm maintaining that sort of tail tuck position. And then I need to bend down for something. I'm more likely to bend with a tail tuck. And that compresses my lower back. It's not the ideal way of bending. A better way of bending is with a released tail and more of a fold at the hips. So what we want to practice are kind of primal movements like squatting and so on, so that we remember how to move without kind of continually bringing about these patterns of activity that have kind of formed for us. So how we do that, as I said alluded to earlier, is taking the body into different orientations. So at this point, if you'd like to find a mat, if you have one, and you want to come to lay on the floor, to join me for this part of the movement practice. So we've got half an hour left, which is perfect. So come and lay down if you'd like, or maybe watch, and you can do these sort of exercises maybe in bed when if you can't get on and off of the floor. So just getting my things sorted here. Take your time, get yourself comfy, maybe grab a pillow or a folded towel, something for your head. And we're going to start off with something which is based on I'm kind of digressing slightly, but I'm going to teach you something which is an exercise to help calm the nervous system. So as you lay down now and fidget and get comfy, I'm just going to talk you through. So there's a chap called Stephen Porges who's done lots of work. He's a psychiatrist based in America. He's done lots of work based on kind of regulating the nervous system. And somebody's written a book based on his work called Accessing the Healing Power of the nerve, of the vagus nerve. And this little practice is going to sort of calm, hopefully, your system, and it will be a good base point before we do more movement. So what I'd like you to do, and I'm going to show you actually in sitting, but I'd like you to lay if you're comfortable to lay, is to cradle your head in your hands. So bring your hands behind your head and encourage your nose to kind of retract back a little bit so that the back of the neck is kind of open. And just let your head be heavy in your hands and just notice your breath as it arises and falls on its own. So keeping your head centered, have a little fidget if you want through your pelvis, through your ribs, so that you just feel comfortable where you are, but keeping your head centered and in the middle. What I'm going to invite you to do is to send your eyes or look extreme off to the right side. So if you're wearing glasses, you might even look at the frame of your glasses, but keep your eyes looking extreme to the right whilst your head stays centered. And notice whilst you're keeping your eyes looking over to that side, keep them there all the while. You're just waiting to observe if anything changes in your breathing, whether you breathe, whether you sigh, whether you swallow, whether you yawn, and keep your eyes looking over to that side whilst your head stays in the middle. And if there is a shift, if something happens, like a change in your breathing, a sigh, a yawn, then you can let your eyes kind of come back to normal. Then you can come out of that kind of position and just bring your hands out from behind you and give them a bit of a shake out then now. Yeah, so sometimes, you feel a yawn, a swallow, and it sort of shifts and resets your nervous system to a quieter level. So if anyone's interested more in the body-mind, Stephen Porges and his work is amazing. He talks about lots of other things, which is not really in my remit today, but we're just going to do the eyes to the other side. So if you'd like to cradle your head in your hands once again, and you can do this in sitting if you like, or laying, and keep your head centered and send your eyes over to the other side now. So you're looking extreme to the left, and keep your eyes looking to the left whilst you quietly notice if anything changes in your breathing at all. So you have to kind of practice this and feel it, but after a while, you might notice, maybe a bit of yawn or a swallow or a sigh, and then there's been a shift in your nervous system. So bring your hands out, give them a little shake out. So you might notice you feel slightly calmer. Maybe your breathing has become a little slower and lower. Okay, so that was a little aside. So what we're going to do then now is practice something called the sniff, flop and drop. And I advise you to get hold of maybe these, I'll show you these little exercise leaflets that I've just printed off from the Pelvic Physiotherapy website, but we're going to practice it kind of in stages. So you might like to come into side lying. You might want to support your head with your hands. You might want a pillow or two between your knees. Now, you're not going to see a lot from me, but I'm going to join in with you and just talk you through kind of what I'm feeling. I'll grab a few pillows. Okay. So maybe a pillow or two between your knees and rest your head down, maybe onto your arm or have your head on something. So you can also do this in sitting if you like. What I'd like you to do is to rest your hand on your sort of upper belly area. So your one hand resting and noticing what your belly is doing, and you're just kind of getting and adjusting into a comfortable place. Just check before you begin that your tail isn't too tucked under, but instead you're kind of fidgeting your bottom a little bit so that you feel your pelvis is in a sort of or the back of the pelvis is sort of a little open, yeah, and release. So what we're going to do is to practice the in-breath, a gentle inhale without the chest rising, just keeping the sides of the ribs and the belly soft, whilst you're taking a very slow sniff of air, or maybe if you can't breathe through your nose, you breathe in with your mouth. But what I'd like to do is to press over your tummy so that when you sniff gently, you maintain a softness, and you can check that by pressing with your hand over different areas of your belly. And what I want you to notice is it takes a lot of focus and attention because we're only noticing something very subtle. So that's why we have to slow ourselves down, quieten everything down to feel. So as you inhale, as you take a slow, gentle sniff of air in, if your tummy stays soft, you maybe sense that your ribs expand laterally, and perhaps that your tummy moves slightly, or the organs are displaced slightly as the diaphragm, the main breathing muscle, descends. And what you might also feel at the pelvic floor is a sense of it dropping and releasing slightly. It's a sense of your back passage releasing towards the tailbone, and maybe a sense of your sit bones releasing, widening, spreading apart. So as you're concentrating, you might be frowning slightly, you might be holding tension in your face. So another visualization to tune into your face. Are the corners of your mouth wide and drifting in the direction of your ears? So if we relax our face, don't worry about how we look, let the face relax as we just squash and press our belly and just repeat that slow inhale to practice what we call the gentle sniff, the flop of the tummy, and at the same time, the gentle release or drop in the pelvic floor. So called the sniff, flop, and drop. But just a good time maybe to practice this if you wake at night, you can't get back to sleep, or you just think, oh, I'll just practice that now. It can be quite soothing and help your body settle to sleep. Or maybe at night time there's less distraction. You can focus more on these quieter, subtle sensations. So we can practice it in side lying. We can also practice it laying on our back. It seems a little counterintuitive because when we lay on our back, the gravity is kind of sending the organs a little bit down and away. But maybe come onto your back now and we'll have a sense of it on our back. So have a feel with maybe one hand on your breastbone and one hand on your belly. And maybe before we begin, just push and pull through your feet. So I've got my knees bent up, feet standing. Just push and pull through your feet to fidget, to sort of circle your pelvis into the floor. And incidentally, if you're feeling the smooth sort of circling, that shows a pretty good body orchestra. Yes, so smooth, easy movement that's pain-free. It shows quite a good kind of neuromuscular kind of pattern. Okay, and then just come to rest somewhere centered. somewhere that feels natural to come to rest. Let one hand rest on your belly, maybe a little lower down now on your belly, one hand on your breastbone on your chest. So what we want to practice with this gentle sniff in is not to let the upper chest lift, not to let the chest lift. Instead, keep the chest quiet and still. So when we inhale, we want to direct the breath more into the sides of our ribs, the sides of our ribs. And when we get that part of our, when we get that sort of pattern going of the chest staying quiet, the diaphragm releasing downwards as the ribs expand to the side, often we get a sense of, ah, yes, now I can feel my my back passage releasing towards my tailbone. So we sense a different feeling, and maybe laying in this position, we can feel how maybe there's a little bit of a subtle forward and backward tipping in our pelvis as we breathe in and as we let the breath go on the exhale. So we're practicing the inhale, we let the exhalation just go. It's a passive process. The elastic recoil of the lungs just allows that breath out. So what I'm going to invite you to practice now is the butterfly kind of opening and closing of your knees. So you can also do this in sitting and feel the same sort of thing going on in your pelvis. So as I'd like you maybe to place a hand on your belly as you press your knees together, and then bring the soles of your feet together as you let the knees open and the tail roll forward. So we breathe out to let the tail roll backwards, and inhale as you let the knees open and the pelvis roll forward. So in our lives, often we spend more time with our knees pressed together, legs crossed, ladylike sitting postures rather than the knees open. Hence, we get a little short and tight and closed down in that back half, back triangle of the pelvic floor. So practicing this is letting the area sort of open fully is really a good thing. Yeah, so we breathe out to close. Sometimes people advocate resting in this position, in which case I would suggest resting a pillow under your thighs, so you've got kind of your legs aren't just resting in thin air, you've got something to sort of lean against. And again, maybe practicing some of that sniff, flop and drop in this position, because your pelvic floor is in a slightly, or it feels more vulnerable certainly, but it's slightly wider, more open position. So we can kind of sense, yeah, what happens here when we practice that sniff, flop and drop. Great, and then having done that, I'm going to invite you to close everything down, because again, you soften and fold each of your knees up, hug your knees in, and maybe bring your head up around your body into a little ball shape, see how that feels. And then wriggle and slide your legs out long, and shake your knees out a little bit, shake your ribs out a little into the floor or the bed, bring your head to wiggle or wobble, and see how it feels for you to gently fidget your limbs a little wider apart, and your legs also, I'm going to come to the side so you can see, your legs also wider apart. So we're practicing stopping and noticing. So in our lives, often we spend a lot of time rushing around, doing, planning, and when even we are stopping and resting, we might be thinking what we're doing next, and our body assumes almost a sense of readiness and tension in our muscles as if we're actually doing that thing. So just stopping and practicing being a human being, practicing maybe releasing a little, will be an interesting part of your healing journey. Yeah? So stopping and noticing. So just sense, how does your breathing feel? Do you sense the breath becoming a little slower and lower? And can you feel the organs being displaced as you inhale, encouraging the sides of your ribs to expand, the chest, the breastbone to stay sort of soft and low, but the breath coming more into the sides of the ribs and the belly. So quite often we're to sort of change your breathing habits, takes a lot of practice. I'm still practicing after 10 or 20 years, so it's something that takes time to bring to awareness and to practice maybe regularly with some movement-based, I don't know, exercise class or some home kind of practice that you might do. So let's stand now, the feet and knees up a little wider. So I've got my feet and knees standing wide apart, arms wide apart. I'm going to gently lower my legs to one side, head rolls to the other, and go from side to side here now. So rolling from side to side, as my top knee lengthens away, I'm aware of my lower back rising up, arching a little more. And then as I bring my knees back to center, I'm aware of my lower back softening, my pelvis rolling back a little. So this exercise is just a dynamic way of bringing about more movement and stretch to the hip joints, to the lower spine and the pelvis. So just going from side to side, experimenting, maybe taking your feet wider apart, closer together, sort of seeing how that feels for you, to have variety, to change. So listen to your body wisdom, maybe bring your arms a little wider, a little higher. So some of these muscles implicated in pelvic pain attach and blend into your diaphragm, and there's fascial links throughout the whole body. So hence, bringing your arms wider and higher and letting gravity support you towards the floor can allow quite a lot of mobilization in the pelvic floor muscles, in the belly muscles, in all the muscles that interrelate together. And pausing and maybe noticing, what's your breathing doing? Maybe pause here for a few slow, low breaths. And when we inhale, we maybe sense the whole body spreading, expanding a stretch, increasing slightly. When we exhale, we might feel the whole body shrinking very slightly. Yeah, so the breath is key. So what I'm going to show you now is a technique that I use with my Franklin ball, which has become a big part of my practice. Having a quick time check there. So I'm going to show you now with this squidgy ball what I do to help release some of the more superficial muscles, some of the muscles underneath as well, by squashing and unsquashing. And this is particularly good for somebody with vaginismus, with quite specific tightening in the pelvic floor. We're going away from the pelvic floor area and we're seeing if there's any tension or knots or tenderness in other muscles away. We're not going to those muscles that are always sort of triggered and tensed up by, we are working away from that area. So I liken undoing knots in muscles a bit like untying, I don't know, a tangled piece of string or something like that. We wouldn't necessarily go straight in for the center of the knot. We'd tease away from the outside, working in. So here, as I'm squashing and unsquashing, I'm becoming more mindful and involved in my own massage. Yeah, I'm noticing my breathing. When I exhale, oh yeah, my muscles soften and I kind of can let the ball sink in a little deeper. And then I can reposition the ball various times. I might also roll onto my side and massage up here around the side wall of the pelvis. Hopefully you can see the ball there. I'm kind of just squashing and unsquashing. And I might even come up to sit and massage directly on the sit bone in this orientation. Yeah, so for some people this might trigger often, maybe it's too much. So you work out, is that okay for you? Because you need quite good upper body strength and control to make sure the ball is where you want it to be, not too much pressure. Obviously, the more you relax your arms, the heavier you lean on the ball and so on. So what we could also do is maybe roll over and massage around the front part of the pelvis. So we might reposition ourselves and roll over onto the front. I'm going to move the ball over to the other side now so you can see. I might also tuck my toes under and to sense how that is to unstick around the front. And as I'm on my front, my eyes are looking up and forward, so my tail is a little more lifted. But if I look down, I might feel, yeah, if I look down, I feel something different in the pelvis. when I look up, I feel more release. And I'm obviously practicing at noticing and sensing subtle things because I've been practicing mindful movement for a while. It might take you a little longer to notice these things. But bring your hand to various places, to maybe your lower back, to sense where you are, can help guide you as to, yes, how you feel. So what I often do is I massage, I squash and unsquash, and unstick the tissues as best I can on one side. And I just use my body intuition as to where to go with the massage, when to stop, when I've had enough. And then I just stop and notice. And what I'm doing with this noticing stage is really important. This is the bit that often we don't do in our lives, in our Western kind of doing lives. We don't actually stop and notice the difference. But when we do stop and notice, we allow it to soak into our own nervous system. And maybe, as I was saying earlier, if the body likes that feeling of it feeling different somehow, subtly, that side of my pelvis might feel softer, lower, heavier, more into the floor. And I might compare how does it feel to roll and move around into the floor on that side. So as I'm circling my pelvis, the muscles need to release to be able to lean into the floor. And it feels a little bit kind of more, it feels like it's leaning more connected now on that side. Yeah, so there's different things that my nervous system is kind of exploring and noticing. And by stopping and letting that sort of sink into your hard wiring, into your nervous system, letting the conductor sense that, oh yeah, it's just a slight difference, but maybe it's these slight differences that are important in changing and changing towards the better. So what I thought I'd also do, because I know Ellie was keen that I did more sitting practice, is just finishing off with a few other sitting techniques. So I'll invite you to come back up onto your chair again. So that was just a few little practices. So come and sit on your chair again. So you can keep the screen off if you want, or have it on. I'm just going to come. Let's bring the chair to this place. Okay, so I'm kind of spotlighting my pelvis a little bit, but that's good. So I'm actually going to sit side on my chair. Hopefully you have got that ability on your chair where you are. Maybe you haven't, maybe you just don't want to watch. I'm going to hang one side of my bottom off of the chair. So I've got one sit bone on the chair and I'm holding onto the back of the chair. So this is obviously best on a sort of classic sort of dining chair. So what I could do is one side of my sit bone is on the chair and I'm kind of making sure that I haven't got, you know, too much pressure or rubbing or discomfort on the edge of the chair. I'm going to drop one side of the pelvis down and then kind of lift it up again. So I'm going to show you a little bit more to the side. So just dropping down one sit bone and then lifting it up. We call this sort of dipping the sit bone, dipping the pelvic, the sit bone down into a pool of water, deciding, oh, that's a bit cold, you might lift up again. So we just see how does it feel to drop down and lift up. So this is obviously mobilizing other joints as well, your lumbar spine, everything works with everything else in your body orchestra. We don't just isolate one thing. Now, excuse the creaking chair. I'm just going to do some circling now. So I'm sort of doing what I call the big wheel. So lifting up, dropping down, maybe reverse the direction, go around the other way. So one side of my pelvis is fixed and supported. I'm holding on with my hand as well here. But the other side is sort of free to have a little sort of move around. Yeah. So then I'm going to sit back onto my chair and just again fidget and tune in. Does it feel any different on that side that's had a little workout? Maybe it does, maybe it doesn't. Have I gone a little bit too big with those movements? Have I brought about pain or protective spasm in the muscles? I might go and do that, but I don't know, a much smaller version of that if I have. Yeah, obviously it's best to go gently and build onto the size of the movement than go to with too much gusto to start with. Yeah, so we could then do the same thing on the other side, and I will just do that for those of you that are practicing with me. We'll have a go on the other side. It's quite good maybe to see it again. So we imagine dropping that sit bone down into a little pool of water, lifting it up again, dropping down. So one side is fixed, the other side is sort of having to release a little as I lift and as I lower. And it's also working here around the waist, closing down one side, opening up this side. Notice that the chair side, the side that's on the chair, is also working. So as I drop this side is closing down. So one side of the waist closes down whilst the other side opens up. So the body knows what to do. The orchestra has done this kind of wiggle before. Then I circle around. It might feel a little strange and difficult to do one side more than the other. We've all got one side that we tend to fix with, one side we tend to do with, which might bring about these sort of imbalances. So just circling up and around in that big circle. Good. And then having done that, until you either feel tired or you think, no, that's enough, I'm cooked, I'm done with that one, come back and sit again. And again, just tune in and notice. And then what I thought I'd finish with is the sniff, flop and drop practice in sitting. And you've got a nice little opportunity to feel maybe around what we call the anal cleft, which is the very top of your bum crack, your builder's bum crack bit, just below that. You could maybe rest a finger or two, just resting on that place. Have your other hand maybe on your breastbone. So maybe just take your attention to these areas. And as you sniff the air gently in, keeping your breastbone hand quiet and still, the air comes into the sides of the chest. The belly stays soft as it expands. And if you're getting the sniff coming in, the diaphragm descending, the belly staying soft, you get the resultant drop here at the hand at the back, feeling maybe a slight release feeling at that area. Or maybe you don't need to feel it with your hand, maybe that's a little awkward, maybe you want to keep a hand on your belly. Is it possible for you to practice and repeat that gentle sniff of air in, as if you're taking in a nice smell? So the idea is you're taking in a very leisurely way, a nice smell. And quite often we're in the habit of breathing in, sucking our bellies in, and sort of doing the opposite of what we're trying to re-educate, which is a sense of the diaphragm and the breath happening maybe in a slightly different way. We're teaching the back triangle to release. So as you slowly invite that intake, that little small, gentle sniff, with the belly staying soft as it happens, you have to really quietly bring your attention to what's going on around the tailbone, around the back passage. As you sniff the air in, you sense a very subtle releasing backwards of the tail. So I was practicing this myself this morning. I woke up and thought, I'm just going to do a little bit of practice now. And I had to really quieten down my mind, and I forget I was doing this for a bit. It takes a lot of focus, and so be patient with yourselves as you practice this key, sniff, flop and drop. Yeah, so it's a gentle sniff of air in. I think sometimes the word sniff makes us think it's got to be a kind of a sniff of air in, but then the belly flops, the pelvic floor kind of drops. And in the next course, I'm going to be talking a little bit more about bowel emptying, how we use the diaphragm, the breath, to optimally kind of empty. I just want to really conclude this morning with practicing that sniff, flop and drop in different postures, different orientations to gravity might just shift your habit, might just shift your orchestra to be able to find a different feeling, a different sense. So doing it in sitting is more challenging than doing it laying on your side. Laying on your back is possibly more challenging than laying on your side as well. Yeah, so there's sort of progressions. And quite often when you see somebody one-to-one, they will practice these techniques with you, observe you, and might even only give you the sniff part of it as part of your practice for the first few weeks. Once you've mastered that and you can sniff with your belly staying soft, then you start to maybe, I don't know, observe kind of the next stage a little bit. Yeah. So quite often these ingrained patterns do take somebody else, another conductor, perhaps to check that you're doing it. But quite often, I think nowadays, we maybe can afford ourselves a little bit of time to become, I don't know, aware, empower ourselves to kind of tune in and notice. But it often takes quietening down. And quite often, I think also with this gentle, subtle, mindful changes, if you're practicing in the presence of somebody else, it may be that that's also difficult to do. It makes it a little too intense and we can't really relax and fully feel for ourselves. We need to take time to bring this practice into home and into quiet time at home as well. Super. Great. Well, I think I'm just about done. I touched on a few other things, but I think I've managed to keep to time. So if anyone has any questions or feels like I'm muting, you can. I'm going to maybe pause the recording now. There we go. So I've stopped the recording.